Hey everyone, my name's Tyler Davis Sanfos. This is the Anesthesia Breathing Systems lecture for chemistry and physics. I know I haven't met you all yet, but I'm looking forward to meeting you all soon, particularly this summer with anesthesia principles. I wanted to give you a little disclosure. If you hear any clinking in the background, that's my dog walking around, so I apologize, but in the era of virtual learning, this is a reality for us all. I also wanted to mention if you have any questions or concerns, please feel free to email me. So our objectives for today are to list the four different categories of anesthesia breathing systems, discuss advantages and disadvantages of each system, calculate appropriate gas flow necessary, and then describe the different type of non-rebreathing systems. So I like to start each lecture with a motivational quote. So this is from Oprah: "Do the one thing you think you cannot do, fail at it, try again, do better the second time. The only people who would never tumble are those who never mount the high wire." I'm sure as you embark on your anesthesia journey, particularly with clinical content, didactic content, this can seem like an uphill battle, but know that we're here to support you as faculty, and if you ever need anything, please feel free to reach out. Okay, so quick review. There's are different types to deliver anesthesia. Today, because we're discussing breathing systems, we'll mainly discuss inhalational anesthesia, but induction of anesthesia is something we think about with inhalational versus IV induction. But as a quick review or overview, inhalational anesthesia is the production of general anesthesia by the administration of anesthetic gases or vapors into the pulmonary system. There's several gases that we use to produce or maintain general anesthesia. Anesthetic breathing systems consist of all the components necessary to deliver oxygen, deliver anesthetic gases, remove carbon dioxide, and then we want to be able to assist ventilation for our patients. Why is that important? So for some cases, the surgeons will require muscle relaxation, and when you relax a patient, you have to breathe for them, and we want to make sure that our anesthetic breathing system of choice is capable of providing that. So next, troubleshooting problems with oxygenation and ventilation. So this content truly is pulling back on your ICU knowledge, but it's something that I think it's really important to review now that you're going to be intubating patients and placing supraglottic airways and whatnot. So I wanted to quickly go over the DOPE mnemonic. This is what I use when I'm troubleshooting an airway. So first and foremost, I think about displacement. So once you have an airway in place, you always want to start at your patient with troubleshooting. So with displacement, you want to ask yourself, is the patient extubated? Has the tube migrated in or out from where you had secured it after intubation? Things of that nature. Next, I think about obstruction. So is the tube kinked? Does the patient have secretions that are obstructing the endotracheal tube? Or, does the surgeon have their hand on your circuit? All things to think about. Next, pneumothorax. If you're delivering positive pressure ventilation that requires high pressures, this is something you want to think about. And that's why it's really important after you intubate your patients that you listen for bilateral breath sounds to get a baseline assessment of how well or compliant your patient's lungs are. And then next, think about equipment failure. So has your ventilator stopped working? Is it something to do with the circuit? Is it something to do with the machine? Have you had a power outage? All things to think about. So again, if you ever have trouble ventilating your patient or having any trouble oxygenating your patient, use the DOPE mnemonic. Think if your tube or airway is displaced, if you have an obstruction, assess for a pneumothorax, or think about an equipment failure problem. So next, resistance to gas flow. So breathing systems can add significant amount of resistance to the patient's work of breathing. Flows generated by our anesthesia machines can be very high, and this can contribute to barotrauma, so that's why we mention it here. Also, resistance to flow can be really uncomfortable for a spontaneously breathing patient. We don't want to give positive pressure ventilation breaths to patients that are awake or breathing spontaneously. Causes of resistance in our breathing systems include unidirectional valves, connectors, tubing diameter, and obstruction. So ways to minimize this resistance, we want to ensure that our endotracheal tubes are adequately sized for each patient. You want to make sure that the diameter of the breathing system or tubing and the connectors are as large as possible, but also not so large that we're going to cause tracheal ischemia. This method or thought process is based on Poiseuille's law. You want to use curved connectors. Again, this is referencing Reynolds number that you'll learn about. Use fewer or no unidirectional valves, and then controlled ventilation offsets resistance. So if your patient is muscle relaxed, they're not going to be fighting you. And then if you're controlling their ventilation, obviously there's not going to be that resistance that they have with their diaphragm working. So there's 4 different types of breathing systems or classification. First is open breathing system, which we'll talk about, like airway insufflation. The second category is semi-open, and it's important to remember that your fresh gas flows have to be higher than the patient's minute ventilation to prevent rebreathing. And we'll talk about our Mapleson circuits here. Third type is semi-closed, where your fresh gas flow is typically less than minute ventilation. We have other components of the breathing system or circuit that allow that to be possible. The majority of our anesthetic breathing systems on the anesthesia machine are semi-closed. And then the fourth category is a closed breathing system. This is where fresh gas flows only replace gas or oxygen that's being consumed by the patient. So open systems, an anesthetic is brought to the patient's respiratory tract with atmospheric air as the vehicle or as the diluent of the agent. It's important to remember with open systems, you don't have an airway device in place. So the respiratory tract is open to the atmosphere at all times, and there's no reservoir bag. What's important to remember with open systems is if you need controlled ventilation or need to assist your patient, you cannot achieve this because there's no airway in place. Different examples of open systems include open drop methods, insufflation method, or the Aries T-piece without an expiratory arm. Okay, so open drop techniques. This is what I like to think of as the Hollywood method of anesthesia, where you see a bad guy cover someone's face with a gauze that's saturated with an anesthetic agent, and then the person falls asleep. So open drop techniques use either ether or HALT. For the record, that's not how anesthesia used to be provided, but it makes for a good movie. So how does this work? Open drop technique used with ether or halothane, which are highly volatile agents. The liquid agent is dropped onto a gauze pad or porous mask that allows this liquid agent to be vaporized via these protective masks. So the different names of the masks are Janauer, Ochsner, or the Schimmelbusch mask. And there's several layers of gauze that cover the wire mesh. What's really neat on the next slide are some pictures of these masks. If you ever get the chance to go to Mass General Hospital, they have a museum, an anesthesia museum, and they have these different masks there. That's pretty cool to see. The vapors are then drawn into the lungs mixed with room air. Here are the ether masks that we used and I referenced on the previous slide. A second is open drop technique. So this uses a wick long enough to reach the bottom of the container, and then the anesthetic or the liquid is drawn up the wick via capillary action, giving a slow, steady delivery rate. So the patient's face have to be protected because they're at risk for burns, and inhaled gases are cold due to the latent heat of vaporization. And you'll learn too, as patients are placed under general anesthesia, they vasodilate and they're prone to becoming really cold. So it's something to consider. Advantages and disadvantages of open drop technique. The advantages, it's simple equipment and it's difficult to overdose because there's a great margin of safety. The disadvantages, they're going to be rebreathing carbon dioxide because you can't support ventilation. It's difficult to maintain a constant vapor concentration. There's hazards of airway fire, skin irritation, and inability to assist ventilation again. The last thing I'd mention is environmental hazard of gas pollution into the operating room. There's not a scavenging system to get rid of the gases that are exhaled. So another type of open system is insufflation technique. We still use this technique today and typically use it for ear, nose, and throat procedures, particularly when they're having airway surgery. For like a microlaryngoscopy, bronchoscopy, particularly in the hospital that I work, we'll keep the patient spontaneously breathing. They'll place an endotracheal tube kind of in the corner of the mouth to where it's not actually in the airway, and you'll insufflate high-dose volatile agents to keep the patients asleep. So insufflation technique, This is an inhaled anesthetic agent delivered into the patient's pharynx, like I mentioned, and exhalation occurs by channels exclusive of the device used to deliver the drug. Again, there's no secure airway, so oropharyngeal, nasopharyngeal catheter, or hook. This method avoids direct contact with the patient's airway and breathing circuit. Gases are exhaled into the atmosphere, and the patient must be spontaneously breathing. So advantages and disadvantages to insufflation. So the advantages are there's no rebreathing of exhaled gases because there's not like a mask or the gauze there were that we previously talked about. There's minimal resistance to breathing, and the equipment is simple. Disadvantages, again, the waste gases are because you require high flows, because there's not a nice secure airway for those gases to be delivered. So you have to have a higher concentration of volatile agent and higher fresh gas flows. Fresh gas flows meaning oxygen, air, and nitrous. Other disadvantages to insufflation technique, there's the inability to assist ventilation, dilution of the anesthetic by room air, and then pollution of the operating room. So what's an Aries T-piece? This can be considered an open system when there's no side expiratory arm. There's a picture later in the lecture. So in this case, the patient inhales air through the open arm of the T-piece along with some vapors and gases from the anesthesia machine. Gases are exhaled into the air via the open arm, and to avoid dilution of the volatile agent, fresh gas flows should be 3 times the minute ventilation. This is a nice summary slide describing the components of a breathing system. So with insufflation and open drop technique, you can see that there's no reservoir bag. There's typically no rebreathing of exhaled gases, with the exception of open drop. There's no chemical neutralization of carbon dioxide like there is with other breathing systems. There's no unidirectional valves, and the fresh gas flow rate is hard to measure. Okay, next, so looking at characteristics of semi-open systems. So we've already talked about open systems, now we're moving on to semi-open systems. These are the components that are contained in a semi-open system. A breathing hose, fresh gas inlet. So the breathing hoses are corrugated breathing hoses or tubing of rubber or plastic. They're usually 22 millimeters in diameter, depending on manufacturer dimensions. They offer low resistance, act as a potential reservoir. You have fresh gas inlet, so gases from the anesthesia machine or oxygen tank enter the circuit through the fresh gas inlet, which varies based on the machine or type of breathing system. Additional components of the semi-open system includes a pressure relief valve. You'll hear this referred to as a pop-off valve or adjustable pressure limiting valve or APL valve. This controls the amount of pressure that you can build up in a circuit, allowing variable pressure thresholds for ventilating to scavenging system. In a spontaneously breathing patient, the APL valve must always be open. If it is closed, your patient will not be able to exhale. So it's really important to remember spontaneously breathing patients, APL valve should be open. APL valves or adjustable pressure limiting valves are important, particularly in pediatric patients if you're worried about a laryngospasm as they're continuing to emerge from general anesthesia. If you need to deliver positive pressure breaths to break a laryngospasm, you would want to close the APL valve. So 2 different examples of when you would want your APL open. If a patient is spontaneously breathing and alert, you would want to close your APL partially to deliver a positive pressure breath if you were needing to control your patient's breathing. Another component of a semi-open system is a reservoir bag or breathing bag, and this is a reservoir for anesthetic gases and allows a method for generating positive pressure. Additionally, there's unidirectional valves included in the semi-open system. This directs fresh gas flow to the patient and exhaled gases out of the system. The advantage is that it allows for fresh gas flow to be near the patient's minute ventilation, but the disadvantages are that this can increase resistance and valve can malfunction if moisture accumulates. Next, looking at Mapleson circuits. The Mapleson systems share certain features with circle breathing systems or semi-open breathing systems. They accept fresh gas flow, supply the patient with gas from a reservoir bag to meet inspiratory flow, volume requirements, and eliminate carbon dioxide. They differ from the circuit system, which is the next system that we'll talk about, by having bidirectional gas valves and lacking an absorber to absorb carbon dioxide. And to eliminate carbon dioxide and prevent rebreathing, these systems depend on higher rate of fresh gas flow. So remember the review slide earlier, I talked about semi-open systems needing fresh gas flow to be higher than the patient's minute ventilation. That's a key takeaway. So if fresh gas flows are less than the patient's minute ventilation, there's a risk of rebreathing because the inhaled and exhaled gases are traveling through the same tubing. Mapleson circuit characterization or labeling. Usually they're labeled A through F, and the way that they are labeled is based on where the components are located within the breathing system. Okay, next, thinking about carbon dioxide. So we know with normal breathing, we typically breathe in oxygen and exhale carbon dioxide. So as patients are anesthetized, this mechanism can be altered by the inhalational agents we give and any other synergistic IV agents like opioids. So why is it important? We want to make sure that we're adequately ventilating our patient and eliminating carbon dioxide. Patients, you'll hear reference, can rebreathe the carbon dioxide if there are certain components that are not working appropriately. So you want to make sure that you have fresh gas inflow that's adequate to wash out the carbon dioxide exhaled. You want to make sure that your patient has an adequate minute ventilation and mode of ventilation. If it's controlled ventilation, you want to make sure that you are supporting them appropriately and your equipment is functioning appropriately. If they're breathing spontaneously, again, you want to make sure that your APL valve or your pop-off valve is open so that your patient can exhale. You want to consider your IDE ratios, the volume of a reservoir bag and breathing bag, ventilation devices, and then CO2 sampling line. So here's just a picture for your reference of different types of Mapleson circuits. So I think the easiest way to think about a Mapleson circuit is to think about exhalation. So we just talked about carbon dioxide. Exhalation, gas containing carbon dioxide, enters corrugated tubing. After exhalation and before inhalation, the fresh gas flow rate continues to wash out exhaled gases. So during inhalation, the patient is breathing in the fresh gas. So as a reminder, if the fresh gas flow is not sufficient or lower than the patient's minute ventilation, the patient will begin rebreathing the exhaled gas that's in the corrugated tubing. So advantages and disadvantages. Mapleson circuits you're going to use most often as you're transporting patients, either with an airway or without an airway. So the advantages, there's less airway resistance, they're convenient, easily scavenged. Bain circuit prevents heat loss, which is a specific type of Mapleson that we'll talk about later. The disadvantages, you can have increased apparatus dead space. It requires high fresh gas flow. There's loss of heat and humidity if you do not have a heat and humidity filter or exchanger that you can place in an airway. Other disadvantages include inefficient use of inhaled anesthetics and environmental pollution. Okay, so first is the Mapleson A circuit. I think it's really important to remember that the Mapleson A is most efficient for spontaneous ventilation. These questions come up often on standardized testing of which Mapleson circuit would you choose for a spontaneously breathing patient versus a controlled ventilation. So something to remember, Mapleson A circuits are most efficient for spontaneous ventilation. So how do they work? Exhaled alveolar gas containing carbon dioxide enters the breathing hose that's pictured here or is directly vented through the APL valve. So you need to have your APL valve at least partially open to exhale that CO2. When there's controlled ventilation, like I said, the APL valve must remain partially closed, and fresh gas flows of 3 times the minute ventilation must be used to prevent rebreathing. Next, looking at the Mapleson B, this is less efficient than the Mapleson A with spontaneous ventilation. Fresh gas flows need to be at least 2 times the minute ventilation to prevent rebreathing, and you can see the differences in the circuits here. Next is the Mapleson C. This is similar to a Mapleson B with a circuit that has a shortened limb, and fresh gas flows to prevent rebreathing is at least 2 times the minute ventilation. Mapleson D is the most efficient for controlled ventilation. So the position of the APL valve and fresh gas inlet is reversed from the Mapleson A. It's efficient with controlled ventilation by forcing alveolar gas away from the patient towards the APL valve. If you do have a patient who's spontaneously breathing, they're going to require fresh gas flows that are 2 to 3 times the minute ventilation to prevent rebreathing. And if it's a controlled ventilation patient or a patient who's muscle relaxed, they're going to require 1 to 2 times minute ventilation to prevent rebreathing. Okay, so next is a Bain circuit. This is the coaxial version of the Mapleson D. You can see here with the green tubing, the fresh gas flow is located inside the exhalational breathing hose. So the exhalational breathing hose is that clear type plastic tubing around the green tubing, which is the fresh gas inflow. So to test the integrity of this system, you use a Pethick test or Pithick test. This is used to assess the integrity. So this assesses the low pressure system and the integrity of the inner tubing. So how do you do this? First, you're going to occlude the patient end of the circuit, which you can see all the way to the right. You close the APL valve, which is that piece of tubing right above like the whitish portion of the circuit. You're going to fill the circuit using the oxygen flush valve, release the occlusion of the patient end, and collapse of the reservoir bag due to the creation of a Venturi defect in the outer tube is an indication that the inner tube is intact. This test will not detect a system in which the inner tube is omitted or does not extend to the patient port or one that has holes at the patient end of the inner tubing. So on a standardized test, I feel like it's important, or you'll get asked, how do you test the integrity of a Bain circuit? Because you can't assess the inner tubing, and the answer is the Pethick test. Disadvantages of the Bain circuit: it's increased resistance. Rebreathing can happen if there's unrecognized disconnection of the inner fresh gas tubing. And then again, you can't necessarily assess the integrity of the fresh gas tubing because it's covered by the exhalational plastic corrugated tubing. Okay, next is Mapleson E. You can see here there's no reservoir bag or no unidirectional valves. Spontaneous ventilation requires 2 to 3 times the minute ventilation to prevent rebreathing, meaning the fresh gas flows need to be 2 to 3 times minute ventilation. And then for controlled ventilation, it's 3 times minute ventilation to prevent rebreathing. Next is the Mapleson F. This is the Jackson-Rees's modification of the Mapleson E by the addition of a reservoir bag with an APL valve. So the advantage of this with pediatric patients, because there's minimal dead space and low resistance. So here are the minimums to avoid rebreathing. So this is just a summary slide. I feel like the type of Mapleson circuit certainly comes up on standardized testing. So for controlled ventilation, the best choice for a Mapleson circuit is a Mapleson D, and the worst would be an A. And then for spontaneous ventilation, the best Mapleson circuit is A, and the worst would be B. Here's another overview and the different types of systems. So the advantages to semi-open systems: they're portable, there's low airway resistance excluding the Bain circuit, and then there's absence of rebreathing if adequate fresh gas flows. Disadvantages: there's pollution of the OR or the environment because there's not an absorber. There's no conservation of respiratory moisture or heat. Higher fresh gas flows are required, so if you're using a cylinder, you're going to run out of fresh gas flows sooner, and it's less economical. Again, here's another overview slide that similar to the one that we reviewed for open systems, breaking down each Mapleson circuit, the components, whether it's included or not. So I found this case study interesting. It's always easier to apply this equipment to patient scenarios. So you're taking care of a 65-year-old female with sepsis who has new onset renal failure. She's presented to interventional radiology, had a dialysis catheter placed, and now you're getting ready to transfer her back to the ICU intubated. During transportation, mechanical ventilation becomes increasingly difficult. The patient becomes hypotensive, hypoxemic, and eventually has a PEA arrest. So here you're thinking about transporting a patient that's going to be intubated. You want to make sure you have emergency equipment ready. You want to make sure that you have adequate oxygen for the transport. You'll learn how to calculate the sufficient amount of oxygen contained in a container based on the amount of pressure. So what do you do next in the event this happens? First and foremost, don't panic, take a big deep breath and think through what's happening. So what happens next? So thinking through our doped mnemonic, was the tube displaced? We don't really think so, right? So you look at your patient, you're transporting them, a lot can happen, tubes can migrate, but the tube hadn't migrated. Is there an obstruction or is there equipment failure? So here you can see in the picture or the image to the left that the expiratory valve was actually obstructed with secretions. This caused inadequate exhalation time, um, which is going to contribute to auto-PEEP. And auto-PEEP is defined as the unintentional increase in alveolar pressure when complete exhalation is not achieved, and it may progressively increase. So as mentioned previously, the patient became hypotensive, hypoxemic, and then went into PEA arrest. For auto-PEEP, this is most commonly seen in asthmatic patients or COPD patients, but this patient didn't have COPD. Auto-PEEP can result in increased work of breathing, inadequate ventilation, barotrauma, and hemodynamic instability. So what happened next? The ET tube was disconnected from the ambu bag with an audible rush of air, and then there was spontaneous return of circulation. So in the analysis, what happened here? The patient was unable to exhale, causing auto-PEEP, which caused her hemodynamic collapse. So keeping in mind, if you're going to add anything to a circuit, it can cause an obstruction or increase resistance. You want to monitor ventilation with end-tidal CO2 during transportation. They certainly would have been able to see that the patient wasn't exhaling fully if you're not able to measure carbon dioxide. And then you need to understand various breathing systems for transport. This is just a chart from that article that I found to be helpful, kind of outlining the transport device systems such as the self-inflating ambu bag, the Mapleson circuits or transport ventilator, and then the advantages versus the disadvantages. Each institution has different types of breathing systems that you'll use. So next, moving on to semi-closed or the circle system. This is the most popular breathing system in the United States. The circle breathing system prevents rebreathing of carbon dioxide by using carbon dioxide absorbents, but allows partial rebreathing of other exhaled gases. The extent of rebreathing of other exhaled gases depends on the arrangement of the breathing circuit and components, such as the fresh gas flow rate. So here you can see coaxial circuits. These are the circuits that we attach to our machines. There are 7 components listed in the circle breathing system. So you have, number 1 is your fresh gas inflow source. You have inspiratory and expiratory unidirectional valves and corrugated tubing. There's a Y piece, an APL valve, reservoir bag, and a canister that contains carbon dioxide absorbents. And just a reminder, unidirectional valves can increase airway resistance, and incompetent valves can also contribute to rebreathing. So here's a picture starting in the upper right-hand corner at like 1 o'clock. You see number 1, fresh gas inflow. You see moving counterclockwise, so moving to the inspiratory valve. There's the inspiratory limb. Here's the Y piece. A key learning or takeaway here is if you have competent or working unidirectional valves, dead space will begin, or apparatus dead space begins distal to the Y connector or any tube or mask between it and the patient's airway. So the key takeaway, where does dead space start for patients? It's past the Y piece. Adding additional tubing past the Y is going to increase apparatus dead space. So for example, if you're doing a neurosurgery case and you're going to be turning the patient's bed 180 degrees and you have to add extension tubing, you want to make sure that you're always adding extension tubing nearest the anesthesia machine and not extending past the Y piece of the breathing circuit. So continuing on our journey through the breathing system, we've gone past the Y piece. Now we're to the expiratory limb. There's an expiratory valve. And next, here's your APL valve. There is a bag vent switch and a reservoir bag. This is a key learning item for breathing systems that when your patient is on the ventilator, the APL valve on our anesthesia machines does not matter. However, if the patient is on spontaneous mode, the APL valve does matter. And again, that's easier to understand when looking at an anesthesia machine, and I'm happy to answer any questions that you may have. So moving further, you can see where the ventilator is located, and then the CO2 absorber is also there. So this is what happens during the inspiratory phase in a circle system for a mechanically ventilated patient with a bellows ventilator. So you'll see where fresh gas flows and how there is mild rebreathing of exhaled gases. Here's a picture of the expiratory phase of when a patient, you can see their lungs there, exhaling gas, and then where it goes. Next, moving on to closed circuit systems. So the closed circuit technique emphasizes the maintenance of a constant anesthetic state by the addition of gases and vapors to the breathing circuit at the same rate the patient's body redistributes, stores, and eliminates gases. So for a closed system, you have to have very low fresh gas flow. There's complete rebreathing of exhaled gases, and the amount of gas that needs to be replaced is this equation. So the patient's oxygen consumption plus the amount of anesthetic gas that was absorbed. The APL valve is closed the entire time. It's difficult to titrate. So closed system is present when fresh gas flow is reduced to the point that the overflow valve is closed and all CO2 is neutralized. These systems contain two unidirectional valves, one on the inspiratory limb and one on the expiratory limb, and fresh gas flows need to be 150 to 500 mLs per minute. This provides for metabolic oxygen consumption. So this is the amount of oxygen an adult, like 70 kilo patient, typically consumes under anesthesia, 150 to 250 mLs a minute. This amount of fresh gas flow replaces the anesthetic gas lost by virtue of tissue uptake. So what are the advantages? The advantages are it's going to conserve heat and humidity. Remember, patients under general anesthesia vasodilate and are prone to getting cold. It's more economical because you're going to lose, or you're not going to lose as much gas, and it's going to minimize waste. Disadvantages, it's challenging to titrate your agent. It's unpredictable and possibly insufficient oxygen delivery. And there's unknown or possible excessive concentrations of agents, so it's really hard to titrate this type of system. Why do we talk about this? I had a preceptor from the VA who talked about closed circle system anesthesia on naval ships to conserve resources. So just for perspective, this is still used, I think, particularly in our military. So again, here's an overview slide of semi-closed and closed systems. Here's another slide from Nagelhout that kind of gives an overview of all the systems that we discussed. Here are my references. And again, if you have any questions at all, please feel free to email me. I'm more than happy to meet over Zoom to discuss this. I know this can be challenging content to learn, but I'm here to support you in your learning, and I look forward to meeting you soon. Thanks.